I can introduce you. Katerina Stankova is a game theoretician at Maastricht University, presenting jointly with her student, Virginia Ardevol. Katerina has been successful lately at translating some of the language and models of game theory into clinical application, which I think is what they'll be talking about today, specifically Stackelberg games in lung cancer. So take it away, you two.
Okay, hello everyone, can you hear me? I guess.
Yes, yeah.
So we are the last talk of today, so we hope to be a fun talk today. And I am here to sort of warm you up while the real stuff is going to be given to you by Virginia. And the first thing I want to say is Virginia established a Twitter account just because I pushed her, so please follow her. I told her it's very important, so that's a very important thing, what I wanted to say as first. And here we are going to talk about our modeling efforts to design evolutionary treatment for metastatic non-small cell lung cancer. And aside of the two of us, this is a joint work with Jakob Nicolas Katre from University Clinic Aachen, Rachel Cavell, Monica Salvioli, and Frank Tausman from Maastricht University, and Joe Brown from Moffitt. So what I'm going to talk about, and Virginia is switching the slides, so there will be maybe a fun element in this if I'm too slow or too fast. So first, I will just sort of recall what we typically assume when framing a cancer treatment as a Stackelberg evolutionary game. That's my part. And then actually Virginia is going to talk about how we apply this framework to first model and maybe predict the treatment results of the non-small cell lung cancer. Some interesting observations, and there will be actually a lot of after conclusions, a lot of discussion points, which I sort of hope we will get your input on. So just to recall, our research and research of our collaborators focuses on framing cancer treatment as a Stackelberg evolutionary game. Why we now call it Stackelberg evolutionary game? Because it's possible that there is like an evolutionary game, well, there is always evolutionary game, in fact, going in between the patient's cancer cells, but we add this rational player who is the physician. And then we are focusing on how does this rational player, the physician, can actually use their rationality and their advantages in actually treating the cancer, where the strategies of the physician are then therapy options, and actually cancer cells somehow adjust to these choices by effective strategies of therapy resistance. And of course, what should be the goal of the treatment are patients' quality of life, and cancer cells adjust their strategies of therapy resistance in order to proliferate and survive. And there are actually two critical asymmetries in this game in advantage of the physician. So first is rationality. So cancer cells cannot really think ahead, cannot think what would be the possible choices they could make, and somehow cannot really reason in the same way as the rational leader. And the other thing is timing. I'm sure there could be a lot of discussion about it, but basically at the moment when the physician does any choice of treatment, the physician changes the game, and cancer cells have to adjust to this. And then basically we study both theoretically and then also in applications how physician can utilize these advantages at the best. I would actually argue, I list here a few papers where I think are examples of this, but I think most of the work in onco would actually fit within this framework. Yes. So now, what is actually, today we are going to take a somehow different angle on this because, well, it's obvious that if the physician knows a lot as a leader in this game, I can achieve a lot. Assuming this physician really acts rationally. But today, what if we have a leader that misses a lot? So we don't know much about resistant mechanisms to the treatment, which they actually apply. The physician does not know much about the effect of treatment on the evolution of resistance in the cancer. And the last one, on the top of it, we have actually limited measurements of treated patients. So is there somehow a way how to still use these advantages where we know so little? So is there still a potential to predict what's going on to happen to patients on this treatment, and or learn what could have been done differently for those patients in case that the treatment fails, so-called after action reports? So In other words, what is the minimal knowledge necessary in order to actually utilize our advantages in this game? And with that, we somehow started a collaboration with Jakob Nicolas Katre from University Clinic Aachen, who has extra data on non-small cell lung cancer treated with immune checkpoint inhibition. All patients are stage 4, all received the same treatment. And only thing which he gave us so far, I hope he will give us more, is a tumor diameter over time. And typically there are not too many of these time points. And also, while these patients have really many metastases, what we typically get is actually a data set with typically 2 or 3 metastases per patient. And now our main questions here, one is like, we focus on both of them, but this talk is more going to be about the second one. So first of all, can we basically, based on the initial tumor volume proxy, so the diameter we have, and the initial trend, so basically what is the slope between the first data point, can we somehow predict what will happen to these patients under this standard treatment? And then the second question is, well, are there cases where we could actually use a different treatment or actually different treatment dosage? With immunotherapy is not really linear, so sort of treatment on and off, such that for those patients where actually the tumor's volumes increase, whether we can actually switch this trend or at least decrease it. And I forgot to mention, these questions are shared with the collaborators, so we added their pictures so that you can imagine them better. And the modeling approach to answer question 2, which we are focusing on a bit in this talk, we basically use a minimalistic G-function model because we know so little. And I really hope we will get some input from you whether this was a good choice, but I hope it is. And then basically, for the situation where actually these tumors go, we want to see whether we can actually optimize the treatment. And with that, I give the virtual floor to the main speaker, who is Virginia.
Thank you. Yeah, so here we have an example of what the data looks like when we plot it. So in the horizontal axis, we have time measured in days from the treatment start. And in the y-axis, we have the diameter of the tumor in millimeters. And yeah, all patients are subject to the same treatment. And usually this treatment starts between the first and the second data point. So we don't have an exact measurement at time 0. And then, as you can see, the trends of the tumor, they differ from patient to patient. So what we want to study is whether these differences are a result of treatment-induced resistance and other patient and tumor-specific factors. So in order to do that, we propose the following model based on the fitness generating function. And here the first equation models the population dynamics, and the second equation describes how the strategies evolve over time. And this is the specific shape that the G function takes in our case. And the first term represents the logistic growth. The second term is the death by treatment, and D is the natural mortality rate. And yeah, here's the meaning of the parameters. Just one comment, M here is usually taken to be the dose of treatment, but in our case, since immunotherapy is not, like the doses of immunotherapy is not correlated to the effect, we only consider M to be 0 or 1, so 0 if there's no treatment and 1 if there is treatment. And furthermore, we assume that there can be a cost associated to resistance, which is realized as a decrease of the growth rate. And we explore 3 different forms of this cost of resistance. As a quadratic function of u, as a linear function of u, and no cost of resistance at all. And so now I will explain how we fit the model. So first we estimate the population of cancer cells from the diameter, and then we cluster the tumors according to the initial volume and initial trend. And in each group, we fix the parameters K, B, and sigma. And then for each patient separately, we estimate the maximal growth rate, the innate resistance, and the initial value of the resistance. And here we can see that in some cases, the value of the carrying capacity is quite high, which could indicate that actually there is no carrying capacity, which would agree with the view of our physician. And here is an example of what we obtain when we fit the model. So here on the right-hand side, you have in red the real measurements of the volume of the tumor over time. and in blue, what the model would predict once we fit the parameters. And on the left-hand side, we have the value of the resistance, the estimated value of the resistance, and we do not have any information about the real values, so we cannot compare it. It's just all based on estimations. So the first thing we did is compare the performance of our model to a basic linear and exponential model. And we saw that in average, the R2 score was superior for our model. And also in most cases, actually, this difference was quite significant, like in this case, for example. And then in order to see if this superiority was due to the higher complexity of the model, or because actually evolution of resistance played an important role, we compared the results that we got with our model when we set sigma to 0 and sigma greater than 0. So basically, sigma greater than 0 means that resistance is evolving with time. Like here, you can see that it changes value over time. And sigma equal to 0 means that U is constant through time. So as you can see in this example, for tumors that exhibit a rapid change of trend, for example, that they initially respond to therapy and then they start growing again, the assumption of evolutionary resistance seems to actually play an important role. And then in tumors like this one that show a more constant and monotone behavior, it doesn't seem to play such an important role. And finally, we explored the differences with the different forms of cost of resistance. So above we have a quadratic and linear cost of resistance, and below we have the results with no cost of resistance. So what we observed in general was that if we assume cost of resistance, the quality of the fit in general was higher. However, in some cases, the behavior of U didn't seem to agree with the intuition behind the model. So there is no clear advantage of assuming cost of resistance. Finally, we recently also started trying to optimize treatment. So basically trying to see if whether switching the treatment on and off could lead to a better outcome for the patient, meaning in this case, whether we could minimize the final volume of the tumor. And the results are still quite preliminary, and we haven't had much time to really to get them. So basically, when we assume cost of resistance, we seem to get that it was always best to either treat or not treat. And with no cost of resistance, we got some cases where modifying the treatment could lower the final volume. But however, we didn't manage to stop the growth. And here is an example of one of the tumors where modifying M. Here on the right-hand side, you can see in black the tumor with constant treatment, and in red, what we get when we optimize the treatment. However, we still need to do further research in this aspect of optimization. And just as a conclusion, then when we assume there is no cost of resistance, maybe adaptive therapy could benefit the patients of this cancer. And also we still need to explore other treatment objectives. So not only minimizing the final tumor, but other definitions of quality of life. And also a main result is that with tumors that change diameter rapidly, then evolution of treatment-induced resistance plays a role. And as a remark also, that the error in estimating tumor volume for small tumors, it can cause issues with the best fit. So our results could be biased in this case. And finally, although this was not part really of the talk, that the model has better predictive capabilities than linear and exponential models used before. And we wanted to finish with some discussion points. First of all, whether there is a reason to assume there is a cost of resistance and how to estimate it. and also whether there is some other information that could play an important role for our model. And finally, if a model with immune cells as active players could be a better choice here. Thank you very much.
I just want to jump here very quickly because I want to use this opportunity to make a commercial. So I'm coordinating this ITN project EvoGames Plus, which means evolutionary game theory and population dynamics. And we are recruiting 15 early stage researchers, PhD candidates. It's a sort of equivalent. And 3 of those will be in mathematical oncology, but all of them will be in game theory, which is, of course, very cool field. So sorry for commercial break.
That's great. Well done, both of you. Yeah, we still have time for a few questions. But before I get to the questions, I just want to make sure that all of our participants don't dart off, because we do have a discussion session right directly after this, and I'll explain more details about that after we go through the Q&A session here. So the first question is from Michael Rotz. Cool talk. How did the physician observe that there wouldn't be a cost of resistance?
Shall I take this one? Wow, I think some of you know him. I think it's a belief. I think it's a strong belief which is somehow related to, I don't know, background of our physician.
No problem. Okay, next question is from Heiko Enderling. Very nice results. How many patients do you have available to fit the model? And how many parameters were patient specific to obtain your fits?
Yeah, so right now I have 83 patients and 160 tumors in total, because some of them have more than one. And patient specific, it's 3. I mentioned the initial value of the resistance, the innate resistance, and the growth rate, maximal growth rate.
I wanted to add, we are actually having a second half of the data. We will get, we are getting more data, and those we use for predictions, but we don't want to overtrain it. But this data, which actually Virginia mentioned, those are used for the fit in this talk.
Yeah.
Okay. The next question is from Fred Adler. Yeah, you might want to pull up this question. It's a little bit complicated because he's asking about the effect of resistance, the term in the equation, m over k plus b times u. In this model, resistance is as resistance does, and this could be replaced by m times u, where u now represents susceptibility with no parameters. Our interpretation of the cost function is then changed but greatly simplified. What do you think about that? I think he's asking mostly to elaborate on the model of the effective resistance. Is it overly complicated? Could it be simplified?
Virginia, do you want to take it, or shall I?
No, you can.
Okay, so basically there is this kind of pre-existent resistance, which we believe is sort of related, not necessarily to the cancer itself. So it might be related to what happened to the patient in advance. And U is actually the parameter which evolves. And it makes sense that it evolves with a gradient of fitness function. Now, if you replace it by one term, of course it will evolve, but then will it do, maybe I answer question with question for you. So how it will evolve then? Maybe we can discuss this later.
Yeah, I think that would be an interesting topic of discussion for sure. Okay, well, I guess with that, I can leave the rest of the questions to the discussion session as well.
May I just answer the one very quickly?
Sure.
I just said to Yannick, yes, sometimes it's better not to treat it at all. So that's interesting. Yeah, for some tumors, not treating will actually be better for. But then you have to think about it as a whole, because there are a few tumors, and you would want that in general. Actually, the trend is good. So okay, we can discuss that later. Sorry, Jeffrey, for
no problem. Very well done, Katerina and Virginia.